welcome everyone to Vision Serve Alliance's webinar on its second Big Data Project report focusing on working age adults from 18 to 64. We have over 150 people joining us today, so it's nice that there is this much interest in this project. We think it's very important too. It's a vital initiative for the very first time, providing data on adults with vision loss to inform policy, grants, and service delivery. Our Phase 1 data reports provided striking insights on adults 65 plus, and in the second phase, the working age adult national and state reports data is equally profound, as you're going to hear. We developed these reports with the Van Nasdale group, just as we did the first group. We went through Ohio State, but this group is the same group that works with Ohio State University's College of Optometry. Before I introduce our illustrious Dr. John Cruz, who's made this all possible, I want to remind you that this webinar is being recorded, and we will make it available on our website on the same page where all the reports are available. And because we have so many people, we're really not going to be able to take many questions in this webinar. So I want to invite you, strongly encourage you to type any questions you have into the chat. We will answer those questions following the webinar, and we will post those as frequently asked questions along with the recording of the webinar on our website. If for some reason you cannot type it into chat, you can send Helen or I an email. I prefer Helen. She'll keep it all organized, and we'll include that in the questions that we answer. And also, if you have any questions about getting a copy of your state's report, you can also email Helen or I about that. So allow me to introduce Dr. John Cruz. He has over 45 years experience in vision rehabilitation, disability, and vision research. From 1977 to 92, he managed the Older Adults Rehabilitation Program for the Michigan Commission for the Blind. In 1992, he joined the Department of Veteran Affairs Rehabilitation Research and Development Center on Aging in Atlanta. Later, Dr. Cruz was executive director of the Georgia Council on Developmental Disabilities, and he joined the CDC in 1998. There, he was lead scientist in the Disability and Health Branch in the National Center on Birth Defects and Developmental Disabilities, and later senior scientist with the Vision Health Initiative in the Division of Diabetes Translation. Dr. Cruz retired from the CDC in 2017, and since then has served in a variety of consultancy positions, and we are blessed to have him currently serving as Senior Data Scientist for Vision Serve Alliance. So without further ado, John,
Thank
introduce
you.
us to working age adults.
Well, thank you for that lovely introduction. Most of the time I think it's just best for me to leave now, so I can just bask in the introduction, and then I don't have to disprove anything that Lee has said. But for the next hour, we're going to talk about the findings from our examination of the 2019 BRFSS, examining people who are working age 18 to 64, who report blindness and low vision in that survey. So it's a lot of data, and I just want to suggest a couple things just to help you with that. One is, with 150 people, 160 people, there's multiple points of view that are represented. And so you're going to interpret these findings from your particular point of view, which is exactly what you should do. And I'm going to throw a lot of data at you. And please, please, please don't try to process all that information. What I want you to look at are the patterns that begin to develop. The patterns are very powerful, and the consistency of the data underlying those patterns. So there's no test in this. Put your feet up and relax a little bit. I'm going to walk through this. I'll try to be as careful, as clear as I can. If you have questions, type those in. I'll try to get to that. So And also in this presentation, I think, when I did the one on older people, I just kind of let the data speak for itself, and then let the audience, the user, kind of interpret how those data can be used. And what I've done in this presentation is I'm tilting it a little bit, more toward a kind of a strategic planning point of view or policy point of view. And so you're going to see that kind of that theme that's woven through this. So in strategic planning, I think one of the first question we should be asking, I think, is who are our customers and what do they want? And so what I want to do is address this first question, who are our customers? And then I think from our findings, we can make some inferences regarding the second. So what I think about is this. When you think about our knowledge about people who experience blindness and low vision, we have a number of sources that we use for that information. Most of it is our personal knowledge and experiences. We have bunches of friends and colleagues and coworkers and clients that we know who have vision impairment or we're visually impaired ourselves, and that defines kind of our experience. And so we can make inferences about people's behavior and their circumstances from that. So that's fine. That's very important. The second, if you're running an agency, is you have administrative data. So um, most agencies, private and public, will collect some a boatload of information regarding the clients that they serve. So the age, the sex, race, ethnicity, the hours of services. You have a whole bunch of stuff that you collect, and that begins to define a population. So you know who comes in the door of the agency. Well, what I'm interested in, and I think the point of view that we'll provide today, is to look at a population from a population-based point of view, and that is by using the BRFSS, we can examine the entire population, not just people who come to the agency, but everybody in that population. And so, the question is, are they different in any way? So what I would suggest is that each of these sources of information are useful. Each has limitations, but they complement each other. So we need to pay attention to what we already know and then what this tells us. What I'm going to suggest is that for some people, you may see these data and you say, that's exactly what I expect. And so this might be a validation process. For others, I think some of the data are really profound. So what we're going to do in this presentation then is we're going to examine the characteristics, mostly from a health point of view, the characteristics of people aged 18 to 64. First, we're going to look at people with and without vision impairment. Just like we did in the older blind study. We compared people with vision impairment with people without vision impairment, and that was the foundation of our findings. But what we're going to do today is first we're going to look at people with and without vision impairment who are working age. Then we're going to drill down into those people who have vision impairment across a number of categories, and I'm going to explain that to you. So we're looking at the differences between people with without vision impairment, and then we're going to look at the within variability of the group of people with vision impairment. I think it's really insightful. Now remember, this is a population point of view, population-based data. So it's not clinical data, it's not administrative data that we're assembling in any way. Today, I'm only going to talk about the national report and going to give you some glimpse into what some of the states look like. There is a fair amount of state level variability, and as you would expect, and so the state reports complement the national report. So just so you know, the data set that we're using, some of you can make this as you can describe this as eloquently as I can, but this data set is the behavioral risk factor surveillance system data. The BRFSS was developed by CDC, I think in 1981 or 84, something like that. CDC financially supports the BRFSS. It defines the protocol that states use, but it's administered by the state. So there is consistent set of questions that can be asked across the country. They're asked in a consistent way. We can then look at state level data, we can look at regional data within states, and then we can aggregate the data into a national profile. The BRFSS samples 440,000 people annually. It's a very large survey. It is the world's largest and oldest telephone survey and uses what's called a complex sampling frame. And all that means is that the BRFSS does not ask the first 440,000 people that walks across the person who's doing the survey and ask them a bit of questions, but you really want to target people who are represented and oversample uh, 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 minorities within the population. So then you have to post survey weighting in order to make sure that it's consistent with the national population. But anyway, just recognize it's a big survey. The survey runs from January to December each year. And then the data are cleaned up, made available typically in May or June of the following year. So shortly we'll have 2023 data available, which will be very contemporary and post-COVID, which I think will be really useful. But the design of the VRFSS is that it addresses health behaviors, things like smoking. So as we know, smoking rates in this country have declined over the years. All my uncles died of lung cancer. I think it was kind of a rite of aging. Everybody smoked. Everybody died of cancer. But now smoking rates have declined substantially. We know that because of the BRFSS. But then there's still this group of people who continue to smoke regardless of all the information that you provide to them. So one looks at health behaviors, the other looks at health risks. And one of those is, for example, is obesity. And the findings from that inform health policy in this country. Now, the other survey we're going to use, and I'm not going to share much with you from this today, is the American Community Survey. It's administered by the census, but from the American ACS, we can develop county level data. So in the state reports, we have county level prevalence estimates for the working age population. Now, this is what's important. The question that's asked in the survey in both the ACS and the BRFSS is, are you blind or do you have serious difficulty seeing even when wearing glasses? That's the question. So I think we tend to over focus, if you will, on the number of people who have vision impairment. It's a big number and it's getting bigger. We know that. And when we're talking about this data, all we're talking about is people who give a positive response to the question, are you blind or do you have serious difficulty seeing even when wearing glasses? Now, the response to that question is a binary response. It's yes or no. It's not a scaled response. It's not how much difficulty do we have seeing. So that's kind of a limitation. Neither the ACS, the BRFSS asks about vision rehabilitation. So there's a lot of things we don't know, but I think this is enough information to really guide us. Just recognizing every survey has limitations. So as I mentioned, we're going to compare people with and without vision impairment in this age group, 18 to 64. And then we're going to look down at some labor force categories and then drill down into education, income, chronic conditions, self-reported health, health-related quality of life, and disability measures. That's kind of my outline for this. And then I want to make some, give some suggestions about how we might try to approach this. So this is information, national information, looking at the population of people with and without vision impairment. So the middle column looks at people with vision impairment. So nationally, 28.9% of people who report blindness and low vision have not completed high school. 28.9% compared to 11%, 12% in the general population. And among people with blindness and low vision, 11.5% have completed college compared to 29.7%. Now, remember that we're sampling people 18 to 64, so there might be some 18, 19, 20, 21, 22-year-olds who haven't finished college, so it might be a tad higher. But there's a difference. Out the gate, there is a difference in terms of education. Education predicts the trajectory of our lives in terms of our success, our ability to generate an income. So there's something going on out the gate. And then if we look at income, and we can stratify this in a fairly fine way at the national level, 42% of people with blindness and low vision all people working, not working, have incomes of less than $20,000 compared to $15,000 for uh, uh, compared to 15% of people without vision impairment. And 8.6%, let me get my cursor on here so you can follow this. 8.4% of people with blindness and low vision make $75,000 or more compared to 41% of people in the general population. So there's disparities both in terms of education and income at the beginning. So I think, so just as as a comment, when we're championing for those of us who try to advocate for children in schools and keeping them in schools and keeping them in college once they get into VR. This is an important finding and a huge disparity. So out the gate, we've got some changes. So then let's look at just some general health conditions. About 16% of people with vision impairment report hearing impairment compared to 3.4% of people without vision impairment. About 20% report diabetes compared to 7%. 7% of people working age report kidney disease compared to less than 2% in the general population. 41% of working age people report depression compared to 19% of people without vision impairment. I selected these for a variety of reasons. Some these variables because diabetes and stroke might predict. It might be part of the pathway to vision loss. And then some depression might be a consequence of vision loss, especially people trying to find jobs and maybe can't get them. But 9.1% of people with vision impairment working age report stroke compared to less than 2% of people without. So already we see people they've not completed as much schooling, they have a lower income, and they have more chronic conditions. This is comparing the entire population of people, working age people with vision impairment, with the entire population of people without vision impairment. Overall, 50% of people with blindness and low vision report fair or poor health compared to 15%. And then there's some disability measures that I don't really talk about, but we'll talk about these a little bit more. But 41% of people with vision impairment report difficulty climbing compared to 9%. 42% report difficulty with cognition, that is remembering, making decisions. 42% compared to 11%, and running errands, which is kind of an IADL thing, is 29% compared to 5%. So again, very pretty substantial differences within that. But now we're going to drill down into this, and so we're going to look at this distribution by labor force participation, and then we're going to look at some of the same measures that we looked at in the older blind population, looking at health, chronic conditions, health-related quality of life, and then we're going to get into some of the strategic policy and practice implications of this, which I think is rich. Now, so it's interesting. The role of the ACS, American Community Survey, is really to inform federal policy regarding the distribution of federal funds. And it really has quite a number of questions that deal with employment and employment status. But interestingly, I think the BRFSS questions, which is really not looking at employment, that's really not the focus of it, but the questions are pretty rich. So I want to go through these 8 categories. We're going to stratify this population of people with vision impairment by these 8 categories. And so I want to introduce each one of them to you. The first category, so the respondent is asked in the survey to describe what their employment status is, and they're given these 8 choices. They can choose one. So are you employed for wages? That is, you're working for somebody else, or are you self-employed? Now, it's kind of an interesting question, certainly. What we don't know, the big limitation of this question is it does not tell us if people work full-time or part-time. It's a big gap in this survey. I don't know if anybody's ever addressed that. Then the second 2 questions deal with people who have worked but are not currently working. So people can respond out of work less than a year. So they've been working, now unemployed less than a year, or they have been working and they're unemployed more than a year. And looking at this distribution is really interesting. We're going to compare it first with people with and without vision impairment. And then you can look at the category of students, and that can be, they can be high school, college, or graduate students for that matter. And then we have a category of retiree. So there could be a little bias, kind of, it's called social desirability. If you're 60 years old and you can't get a job and you're kind of discouraged from getting a job and people won't hire you because of an ageist response, you might say, I'm retired rather than nobody will hire me or I can't get a job. So there may be a little wiggle room in what people are telling us with this retiree. So just keep that in mind. And there's a category called homemaker, and people can be homemakers for a number of reasons. Mostly if they have enough money to stay at home. And then this category of unable to work. And this is the findings with this category are pretty dramatic, and I think we have to mine it to figure out what we mean by that. So now let's look at what happens. Let's look at the distribution as we compare these categories among people with and without vision impairment. So 60%, about 71% of people with vision impairment report that they are working either for wages or they're self-employed. That's pretty good. I'm sorry, no, that's without vision impairment. I apologize. Compared to 36% of people working for wages nationally and 7.6% of people unemployed. So it's about 43, 44%. So about half as likely to be employed. In terms of being out of work less than a year, about 3% of people without vision impairment report being out of work compared to 6%, so twice as likely. This is pre-COVID. So given the booming economy, this might change if we look at 2023 data. People out of work more than a year is 3.3% compared to 4.5%, which is kind of pretty close, I think. This is troubling to me. 7.2% of people without vision impairment are students compared to 3.9%. There's a fair amount of variability state to state. I think in Kentucky, 6.6% of working age people are in college. So we know that it's really important for people to get into college because that, again, that predicts the trajectory. So I would like to see more people with vision impairment who are getting into college if that's possible. And then the number of retirees, there's not so much difference of 4.2% compared to 5.1%. Homemakers, 6.1% compared to 8.1%. This could be the same thing, the same problem with retirees. Could be people, mostly women in this category, who can't get a job, don't have the skills to get a job, don't want to work. So we don't know exactly what that means, but about 8.1%. But this is the finding that I think that is pretty dramatic. Nationally, 6.3% of people without vision impairment report that they're unable to work, and 29% of people with vision impairment. Now, this group, people without vision impairment, that includes other disabilities. That includes people with mobility impairment. It includes people with cognitive impairment. So, I have one daughter who has cerebral palsy, has power, uses a power wheelchair. So she would be kind of in this without vision impairment group. My other daughter has Downs. So she would be in this other group. So this includes the rest of the population, people with and without disability. So this population is different when we're comparing. Now let's drill down. Somebody asked me, what are kind of the unexpected findings in this? Now, I think one of them is this unable to work is so large. And as I've already mentioned, I think it's unexpected. It was kind of unexpected that this lower percentage of proportion of people who are in college. But then we're going to see higher prevalence of poor health, depression, chronic conditions, and what I call excess disability. And that's where we're going to go for this. Now we're shifting gears. We're just going to look at people who have vision impairment in working age by these 8 categories. So it's a lot of information, but just look at the pattern. Don't focus on these particular numbers. You can go back and do that when you're trying to advocate for a particular issue. But among people who are employed, 10% have less than a high school, less than 8 years of college. 12% have some high school, but not high school graduate. And then 17% are college graduates. So these are the people who are working. We don't know if it's full-time, part-time. And then the pattern kind of sustains itself among people who are self-employed. 10% have less than an eighth grade education, 14%. Remember, this is contemporary data. This is 2019 data. 14% have some high school, haven't completed high school, 13% have completed college. So these are the people who are working. So one would assume that there would be a higher education associated with that. Now let's look at the people who are out of work and how they differ. They're more likely to have less than an eighth grade education, 13%, and 9% or 10%, so not much difference here. More likely not to have completed high school, 16%, 25, 26%. And they're not as likely to have completed college. So there's some of the doors might be closing for them around education, but it might be some other things as well. Then if we look at the students, of the student population, some of these are people who are still in high school, so 7%, and 16.7% are college graduates. These again are among the student population. Retirees, they're kind of evenly distributed. Homemakers. Now here, look at the homemakers. This is I get, and it suggests the options people have. 50% of people who say they're homemakers have not completed high school, and only 3.3% have completed college. And those unable to work are more likely to have lower education. So education is associated. The higher the level of education, more likely people are to be working. No surprise, I guess, in that. Now let's look at self-reported health. So one of the questions in the BRFSS is just how's your health, and would you categorize your health as excellent, very good, good, fair, or poor? So 32% of people who are working say their health is fair or poor. 33% of people self-employed say their health is fair or poor. 50% of people who've been out of work less than a year say fair or poor. 53%. So now if you're looking at this through the lens of vocational rehabilitation, I'd be looking at two things. Well, I'd be looking at a whole bunch of things in here. One is I would be looking at these two groups of people who are employed, and I would say, are they underemployed? And can we get them better jobs? And can we do anything to support their health because they continue to work? And then I would look at people who have worked, and I would assume that if they have worked, that they would likely want to work again. And so perception of health might be a barrier, might be something that you want to address in this. 24% of students report their health as fair or poor. I don't think it's just associated with a pizza diet. 60% of retirees, 57% of homemakers. But look at this. Of those people who report that they're unable to work, 76% report their health as fair or poor. So from a general rehab point of view, there's opportunities across all of these populations to address health as a part of the rehabilitation intervention. The other thing I might add about this category of unable to work is again, we don't know altogether what's going on in that. You can just imagine somebody who, say they have SSI or SSDI, and they get a call from the government, and then they start asking these questions about employment and income, and so some people, you don't want to say you are working if you're getting SSI, so, and you might say you're unable to work. That might be a bias, but when I look at this, people who say they're unable to work, they're shouldering a lot of responsibilities. Now let's just jump from for health. Let's look at depression. So we know there are high levels of depression, but let's see how that's distributed across this population. 29% of people who are working for wages report depression. 24% of people self-employed. So in the 20s, people out of work, less than a year, more than a year, in the 40s. People who are unable to work are in the 60s, 63%. So high levels of depression. If we look at diabetes, we get a similar kind of pattern. Now, it should be by this point, we can see this distribution, this pattern in the population, and it suggests the complexity of the circumstances of people who are working, want to work, and who are out of the labor force. but 9%, about 10% of people without who are working for wages self-employed report diabetes. 34% of people say they're unable to work report diabetes, so almost 3 times as high. So within this group of people who are working age, there's a lot of variability in the prevalence of diabetes. As you probably would expect, it's pretty low in students. Now let's go to hearing impairment. We get a similar kind of distribution. 11% of people who are employed for wages, 16% of people self-employed report hearing impairment. I would kind of expect retirees. Now these are people going to be probably in their 50s and 60s, because the top in this is 64. So it's going to be, this distribution is kind of reasonable, but 25% of retirees reporting a hearing impairment. 22% of people who are unable to work report hearing impairment. So we've all, we spent, all of us, I think, have spent a lot of time looking at this dyad of hearing impairment and vision impairment. And we've also looked at diabetes and vision impairment and depression. We tend to look at these issues as if it's a pair, and that's the way things are. Somebody has a vision impairment and a hearing impairment. But that's not the case. I mean, that same person who has hearing impairment and vision impairment may have depression, may have diabetes, so they're managing a lot of things. So we don't want to oversimplify the complexity of this human experience. In the survey, in the study that we did for you, we looked at, I think, 13 chronic conditions, including stroke, heart disease, asthma, high cholesterol, any cancer, heart attack, COPD, kidney disease, and arthritis. In all cases, people with vision impairment are more likely to have these conditions, people without vision impairment, but the same pattern applies. There's the same hierarchy of conditions across those. Now, I want to look at within the BRFSS, there's a thing called the Health Related Quality of Life module. And there's several questions. One of the questions we've already looked at is, would you say in general, your health is excellent, very good, fair, poor? We've seen the results of that. Now I'm gonna look at 2 other questions, and if you haven't heard me give these talks before, I think these could be used as administrative data. They're pretty rich. They're certainly well utilized in the field outside of blindness and low vision. But the question is, now thinking about your physical health, which includes physical illness and injury, for about how many days during the past 30 was your physical health not good? And then the third question is, now thinking about your mental health, which includes stress, depression, and problems with emotions, for about how many days during the past 30 was your mental health not good? And then the last question is, during the last 30 days, for about how many days did your poor physical or mental health keep you from doing your usual activities such as self-care, work, or recreation? Now, what I like about the question is this, is that the responses are 0 to 30. And as a administrative question, if you're asked this question at entry, some people are going to come in and are going to say, how many days out of last year? And going to say 30. It's tough. And then you do provide vision rehabilitation to folks, and you're giving them autonomy, and you're giving them some skills, and they find other colleagues who have similar experiences, and their mental health and their physical health, their perception of that improves. And so somebody might go from 30 days at entry to 15 days at exit. Well, that's a huge improvement, and people can kind of understand the concept of health-related quality of life. So what I want to do, so when these data are analyzed, typically what is calculated is the percent of people who report 14 or more days, and that's what I'm going to show you. You can do this any number of ways, but you can just count the number of days pre-post, or you can just look at the percentage. So this is just looking at the physical health question. And so just so we're on board, 16.5% of people who are employed for wages report 14 or more days of poor physical health. 19% of people self-employed report 14 or more days of poor physical health. You see the same pattern that gets repeated. Even students, so there's going to be people in their 20s, about 13% report 14 or more days of poor physical health. Retirees is really high, and then this group of people reporting unable to work is 60%. So look at this, it's almost 4 times as likely people unable to work are about 4 times as likely to report poor physical health as people who are working. So there's a lot of variability within the population. Then if we look at the mental health question, same thing. 25% of people, 22 to 25% of people who are working report frequent mental health problems, 14 or more days of mental health concerns. 30% report of people out of work report mental health concerns. 51% of people unable to work. So again, the same pattern gets played through that. So now I want to talk about the last kind of category of questions, and moving along a little faster than I thought. So maybe we'll have opportunity for a few more questions. But in the BRFSS and the ACS, there are 6 standard questions that are asked to characterize disability. That I don't know anybody who loves them, but it's kind of what we got. There was a big brouhaha within the blindness community and other communities to scale these questions. I don't think it was scaling that was the issue, it was the analytical approach that was concerning to me. But the 6 questions that are used in BRFSS and the ACS are: do you have serious difficulty hearing? It's not any difficulty, it's serious difficulty hearing. And the vision impairment question is, are you blind, or do you have serious difficulty seeing? So it's not any difficulty. If you want to double the size of the visually impaired population, you can ask a different question. If you ask the question from the National Center for Health Statistics, which is, do you have any difficulty seeing, we get twice the prevalence rate. But this, for our purposes, I think this is a better question. And then the question about cognition, it asks, do you have serious difficulty concentrating, remembering, or making decisions? And the idea in that question is to capture anybody who might have a cognitive limitation. So if you're trying to capture somebody who has dementia, who's an older person, or somebody who has intellectual disability, has Downs, for example, might be captured by that question. So it's a very broad question in order to do that. Now, what we see is a lot of students who are reporting difficulty remembering, or they respond to this question in a positive way, but I think they're probably focusing on this. And I just think about, I spent too many years as a student, and I have more test anxiety than anybody, I think. But when you think about having to memorize boatloads of information when you're a student, that becomes its own pressure, and something that they're saying that they have. It's a serious concern. And my question is, do we do enough to address that? There's a question asked about serious difficulty walking or climbing stairs. Again, serious difficulty. Then the last 2 is, do you have any difficulty? Do you have any difficulty dressing or bathing, or any difficulty doing errands alone, such as visiting a doctor's office or shopping? So just notice that the 4 of the 6 questions have a severity kind of severity built into it, and the other questions just asked. So here's what we get. Again, this is, I think, hugely informative. 20% of people who are working indicate they have difficulty climbing and walking. Now, I want to interpret this question. So the question in the survey is, do you have serious difficulty walking or climbing steps? And what we know is that there's a huge disparity between people with and without vision impairment to begin with. And what I think we have to be very careful in interpreting those findings. But if somebody has not had orientation mobility training, and you ask the question, do you have difficulty walking or climbing, the person's probably going to say, yeah, I do. And it might be, in some cases at any rate, that appropriate orientation mobility instruction might remediate that concern. Now, we don't know. We can't drill down into the data. The data don't tell us that. But given the disparity and given what it is that we do, that seems kind of a reasonable avenue to think about that. So here's what's important to me. This group, these people are working, but even 20% of them say they have difficulty. So does that mean that there's a mobility problem that they have, or is it a lack of orientation mobility instruction? Could that be improved, I guess, is my question, so that's one less barrier that somebody has to deal with. And then look, the same pattern 30% of people. So here's people who have worked. We assume they want to work, but 30% of them and 43% report difficulty walking and climbing. So we've already looked at education. Well, that's a barrier. We know their income is poor, but can we do some things that might remediate these concerns about walking and climbing and get people back into working? That's just the question I would ask. And then among people unable to work, 75% report difficulty walking. So again, this huge disparity between people who are working and people who say they're unable to work. And then if we look at the concentrating, remembering, 30% among people working, 40% among, it's like this gets played out over and over again. 40% among people who are out of work. Look at this, 36% of students. See, this is the point I was trying to get at. If you're a student, processing lots of information. If you ask me, I would, when I was in graduate school, I would say, yeah, I have a hard time trying to remember all this stuff. So are there strategies that could be employed? Then 61% of people who are out of work say that they have difficulty remembering. So we have substantial barriers, I think, to employment. That. So what's some of the things how do we begin to interpret this? And the one thing that occurs to me is just the grit that people who are in the workforce. I mean, they've got a lot of stuff going on, and with general health, depression, multiple chronic conditions, and they still work. And I mean, you got to really hand it to people who have the grit to continue to work in that. So I think that's something to celebrate. It's also something to say, can we do something about? Can we improve those circumstances? Can we give people jobs that pay more? Can we provide skills training that might lessen the burden of, say, getting to work? And can we do something about depression? Certainly people who are out of work trying to get into work are we can understand why they might be depressed. So then the other thing that occurs to me is this notion of excess disability. So what we see across people with and without vision impairment is a substantial difference of people who are reporting disabilities in these various categories. Some, I think, can be overcome. So if you think about things like running errands, the walking question might be a mobility question, running errands might be a mobility question, but certainly within the domain of what vision rehabilitation does. And then I think there's all kinds of inferences that can be made from this, and let me suggest some of them. One, I think just this data, I think is powerful in terms of strategic planning. So who's our customer? Well, our customers have a lot going on. It's not just one thing. There's a lot of things we have to address, and it drives policy development. So, one big that we all are aware of is just how burdensome it is for a person who wants to work to move from receiving Social Security disability, and go into work. And then if they can't continue to work, then you go to the back of the line for Social Security or SSDI. And so it's these policies that really discourage work. If someone could honestly say, I can work, I can go to work. I don't know how long I can. I'll work as long as I can, but when I can't, then I want there to be those supports behind me. And that's not the way the system works. So there's these big policy things. The other thing I think we can do with these findings, there's always potential to engage other stakeholders. A lot of partners who have an interest. Public health has some interest, although not real keen, I would say. Federally qualified health centers, aging, certainly. The Administration on Developmental Disabilities would have interest in all this. So there are other stakeholders that we could probably engage. And then I think one of the things that, at least from my point of view, having worked both in vision rehab and in public health for half my career in working as in a clinical administrative way, and then other half my career in doing research, is that I think some of these findings can help us think about how we can redefine the outcomes that we achieve. And so we know, without question, that if we provide good services to people, we're teaching them some communication skills, we're teaching them more orientation mobility skills. We're you know what we're not teaching the skills. We're giving people autonomy, agency, and control. And those are the important things. But we can measure part of that in terms of improved health and quality of life. You look at the quality of life measures, for example, I just think that as a pre-post measure, you'd see substantial gain in that. Now, I haven't done it. I didn't do it when I was in Michigan. That wasn't available when I was in Michigan, and I don't know anybody who has done it, but I think it'd be cool. So, here's kind of a lesson that I just want to just kind of share with you and see what you think about it. What occurs to me and what we lament in kind of in the broad vision eye health care system is the incredible fragmentation that occurs. And that washes into vision rehabilitation. We've got these systems that just operate autonomously in their own little constellation, their own little universe, and they don't talk to each other. And we lament that. We'll say, well, ophthalmologists don't refer for services. Well, they often don't. Sometimes they do, and that's really wonderful when it does. But it's this fragmentation. Kind of vision rehabilitation is further isolated in that. I mean, we're not really linked. The vision rehabilitation system is not linked to the eye care system, but it should be. It should be. I mean, logically, it should be. That's nothing that is new, but it's not. And what vision rehabilitation does is not recognized as part of the healthcare system, and it's not recognized as health promotion. But you think about what clinically, what we do. We're doing a lot of things around mental health, physical health, the cooking skills translate into nutrition, mobility translates into exercise and conditioning. So there's a lot of overlay here that I don't think we recognize. Some of the other things that drive this that we all know about is just the lack of vision of rehabilitation, reimbursement for vision rehabilitation, just the isolation of vision rehab from other health concerns, PTOT. And what I already mentioned was that it's impossible. I guess that's the way. It's not just hard. It's impossible to move into and out of the workforce as health permits. And these are huge limitations, and it's things that we're concerned about every day. So there's this guy named Hugh Taylor in Australia. And Australia and New Zealand have been in the forefront of a lot of thinking in terms of public health and vision rehabilitation. Trying to think of the guy who he taught at Western Michigan University and then went to New Zealand and established a vision rehab program there. And now he talks like a New Zealander instead of a Michigander. But anyway, Hugh Taylor developed this model they call leaky pipe, and everybody in kind of the community of vision and eye health just fell in love with this. But but it applies to the Australian system, which is different from the American system. But the whole idea is that somebody comes in from the outside and they go into optometry first, a different model than in the US. So primary optometry becomes the primary care provider. And in Australia, because it's there's a waiting list to get into optometry. So you see an optometry, the optometrist might or might not refer to an ophthalmologist. Then there's a waiting list, and then they get care and so forth. The idea is that all throughout this model that people fall out of the system. So I spent kind of an afternoon just trying to draw what I thought the American system looked like. And all I had were just these little pieces of the pipe, that just kind of randomly they weren't interconnected in any way. So I ended up with this model. So this is my model of the vision healthcare vision rehabilitation system in the United States. It's extraordinarily fragmented. And what typically happens, when you're trying to do a puzzle is somebody said you get to look at the top of, oh, you can't see this because but you have image of what you think the puzzle should look like. So it kind of got a go by. We don't have a go by. We don't know what the system even should look like. But occasionally these fragmented systems come together, and when they do, they're wonderful. So some blindness agencies have great relationships with ophthalmologists in the community, and so these two pieces of the puzzle they get united in some way. um, there's an agency in Savannah. They work with the Federally Qualified Health Center, so that little link occurs with the blindness agency, and they use the Federally Qualified Health Center to identify people with vision impairment. And they have, again, a number of health conditions that are being addressed in the Federally Qualified Health Center. So we have all these pieces, and I think our challenge is to not hopefully we could weave it into one elegant model, but I think the opportunities really lie where we can build some kind of coalition just to link these in one or two or three pieces to make this more of a system instead of the hugely fragmented system it is. So here's some of the things that I think kind of inform that. And and this is just my idea that I've been toying around with. But here's I think kind of take home message when we look at the population. One thing we know is that the population of people with vision impairment it's large. However you describe it, it's large, and it's also getting larger. And so what we have done with the work that we've shown today is the experience of vision impairment is dimensional. It's not just vision impairment. It is this highly dimensional environment where people have chronic conditions, depressions, poverty, health or quality of life, disabilities, educational attainment, and so forth. And that characterizes the population that we serve. And we have to tailor the services that we have to those various constituencies because there's opportunities within each of that. So it's important that we recognize that this human experience of vision impairment is a dimensional experience. But I think the other thing that's important, so you can look at cross-sectional data all day long, the way we are right now, and you can describe a population. But I think it's important to note that this experience is dynamic. It's going to change, and left alone, it's going to get worse. And so the question I have is, if we think about these trajectories, what can we do to modify that? And therefore, I come to the conclusion that this experience is malleable. That's what we know. If we provide very good vision rehabilitation services, we can kind of bend the curve on all these things that we've been talking about. And we can improve health, we can improve a variety of employment outcomes. So I think part of the way we do that is to link with others. So this hobby horse I'm running is this dimensional experience, dynamic experience, and malleable experience. We don't want to give up on any of this. We can change the trajectory, and I think that's what's important. I think it's also important when we're looking at these data is to assert what we're trying to do is describe a population of people working age across these characteristics. It could very easily be a blame the victim kind of study, which I would assert it's not. It identifies opportunities, but we have to be very careful in terms of interpreting it. So a couple of things I want to just suggest to you that just influence this field. Like last time, I think when we had a large meeting of VisionServe, one of the speakers was talking about social determinants of health. And I think that's an important approach to this. The whole idea of social determinants of health was developed by a guy named Michael Marmot. He's an Englishman, and he was studying the British civil service, where they have incredible records. And essentially what they found was the people who had higher status jobs and more money had better health, they lived longer. Because they had more money, they could buy better food, they could exercise, and just have more control over their lives. And typically there were upstream factors like, where they were born, educational level, and income that predict the trajectory of their lives. But if you grow up in poverty, if you grow up in a household where there's very little education, and people aren't eating well, then there's downstream effects. I mean, this is a pretty logical model So the upstream factors might be place, education, income, but the downstream effects may be chronic disease, poor health, poor work opportunities, reduced longevity. So there's a bunch of factors. Now, Michael Marmot developed this idea some years ago, and for some reason, about the last 2 or 3 years, it has gotten so much traction in the federal government, especially in Centers for Disease Control. But everybody's talking about this, and I think when you think about our work, we can kind of frame this in kind of a social determinants of health model. So just keep that in the back of your head. Now, here's one other thing I want to share with you is the question is, does place matter? So we're producing state level reports. And I just want to give you a glimpse of some states. These are just chosen at random, so there's no accusatory or anything that's going on. But I just want you to look at this. I'm looking at 5 states. In Alabama, remember we've got these categories. 29% of people blind people in Alabama report they're working. 45% say they're unable to work. In Massachusetts, 41% of people are working compared to 22%. Look at that, 45 to 22. In Kentucky, 29% are working compared to 34%. Maryland, 42%. Maryland looks a lot like Massachusetts. 42% are working. 27% are unable to work. In Indiana, 36% are working, and 35. So you get this. Now it's not just state level variability. States next to each other. So Alabama looks a lot like Mississippi, looks a lot like Louisiana and Arkansas. But there are huge regional differences across this country, and we need to pay attention to that. Look at perception of health. Alabama, 56% report poor health. 42% in Massachusetts, 41% in Maryland, 57% in Kentucky. So look at that 17%, 15% spread here. Depression, same thing, 52% in Alabama and Kentucky, 31% in Maryland. What's going on in there that makes these so different? I really don't know. And I think that's for more inquiry. We really, you know, this study begins to me to really begin to identify a research agenda to get underneath of this. We know a lot of the reasons why that is, just because we've been in the biz, but we don't know precisely. The other thing I just want to recommend to you folks is that when I was the CDC, I was the CDC lead for a study conducted by the National Academies of Sciences, Engineering, Medicine. It used to be called the National Institute of, the Institute of Medicine. And it published in 2016. It's a massive report. It's like a 500-page report that deals with vision and eye health. But there's a chapter that I mandated that deals with vision rehabilitation. But a lot of the thematic issues in there are the things that we've been talking about: partnerships, who owns the problem. It really should be owned by multiple people. The opportunity to create multiple coalitions and partnerships across the country. So I'm about 5 minutes early, which allows us to do a little questions. So thank you very much.
Oops. John, there are several questions in Q&A, so I'm going to take those first and urge others of you who still have questions to type them in either Q&A or chat or email them to us. And I just want to say that the accessible version of the slides is in the chat, a link to them, but we'll also have available on the website the original slides. So first question, this is actually twofold. So John, is the unable to work, quote unquote, segment inclusive of people who may be discouraged by not being able to find a job, or are a part of what we call the discouragement rate, quote unquote? Some people we know state they can't work when in fact they can, but they don't know that they can.
Yeah, we don't know. So just remember, all these surveys have limitations, and what's important, I think, is that important in all of this is that we look at these questions and the responses from our point of view, and so all we know in this survey is that if asked which of these categories do you belong in for these 8 categories, that's what they chose. We know nothing more about what drives it. Now, but it doesn't mean it ends there. It means that how knowing what we know, knowing that there's such a high percentage of people say they're unable to work, trying to deconstruct that in some way to figure out what that is, it is a challenge. But I think that's a question that should be asked. I mean, I think what you can see in this is that for a lot of folks, there's a lot of reasons not to work, uh, and it's their grit. It's they're working in spite of these other concerns that they have. And so I don't know that we understand that fully. I think we understand it at kind of the individual level when we talk with folks, being able to try to understand that more at a population level. So great question, but we just don't know. But I think it is your professional experience is going to allow you to fill in around that and probably not be surprised by those findings.
Thank you. There's a second part to that question, but I think it flows in that same vein. Could very well be that there are lots of reasons people say they're unable to work.
Mhm.
We don't we have to drill down to understand that
Yeah,
better. But
yeah,
like you said, Dr. Cruz, lots of opportunity.
yeah.
So another question in the slide that shows the percentages of physical health, I want to ensure I'm reading that chart correctly. And what Dr. Cruz stated, which is those who consider themselves unable to work are 4 times more likely to identify themselves as having poor or fair or poor physical health. Am I correct?
Yeah. So the question is, uh, now thinking about your physical health, which includes physical illness or injury, for about how many days during the past 30 days was your physical health not good? Now, of that, for the people who are unable to work, 62% of the people who said they were unable to work reported that they had 14 or more days when their physical health was poor. Yeah, dramatic finding.
Great. And I'm going to take one more. And I think the answer to this question is no, but let's see what you think, John. Is there data on the correlation between access to services for people who are blind or visually impaired and the percentages among states?
No, no. Short answer is no. The only survey that asks about vision rehabilitation services is the National Health Interview Survey, and there is a vision module, and it's asked about every 6 to 8 years, so it's asked intermittently. And the case definition, remember, case definitions are important. The case definition of vision impairment in that survey is, do you have any difficulty seeing? Yes or no. And then if you say yes, then there's a skip pattern where people are asked, are you blind? So you get that those percentages. And then what we found is nationally about 3% of people who report vision impairment get access to vision rehabilitation. And there's some other questions in there that deal with like technology and so forth. Now, here's what I want to suggest to you, depending on where you are. The BRFSS is a great survey, and the people who run the BRFSS feel hugely underappreciated. And so if you have a relationship with the Department of Public Health in the state, you might just look up the people who run the BRFSS and say, we ran these data, and this is what they look like. They certainly haven't run it. I mean, they're just nobody's interested in it. But what you could do is you could make a case for adding a question in a particular state that would be like again a skip pattern. So the people who report vision impairment, you could then have a question that asks, you could have a definition of this, but have you received vision rehabilitation services that include blah 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 blah? There's a standard question that you could use, but you could do that, and you can get a sense, well, what's the population? Among that population, who's receiving vision rehabilitation services, and then you could begin to look at a little yeah, Yeah, you'd have some geographic distribution that you could look at. But there's possibilities of exploiting this survey for state level data.
Thank you. So we are about at the end of time. If you stay on just a couple of moments, I'm going to answer a few general questions for the group. One participant asks, are these state reports ready yet? So we are producing state reports as they are financially sponsored. And so it's a little different with the working age adult from the aging and vision loss reports. Once once the working age adult reports have been financially sponsored, those reports are sent to those who have financially sponsored them. And if they want to share them with their networks, they're welcome to. Anybody else can go online and pay $250 for those reports. These reports are a lot more expensive, so we're just trying to recoup our investment. If you don't see the report available for sale on our website, that means no one in your state has sponsored it yet. And if you're interested in gathering a coalition to do that, please contact me and I can help you pull that together. So that was one just general question that I wanted to answer for everybody. And then there was another question about future analysis of this report. And wow, as John said, there's probably a decade worth of research agenda questions that arise from these data. But Vision Serve Alliance does not have the funds at the moment to generate any of that data or analysis and further research. We sure are looking for partners to help do that because there's lots more we'd like to know about this. And one last question was asked about how we approached participants for these surveys. So, might you explain how participants are approached or selected? And there is no indication as to whether those participants in the survey have had access to blind rehab services. That's not a question that's asked. So again, it's not our survey. We're analyzing, Dr. Cruz and his team are analyzing data from surveys that are conducted by the federal government and state governments.
Yeah, I don't want to go into too much detail. If somebody's no, the first thing I want to say is I just love it when people are looking at these findings and then they're asking other questions. And that's exactly what we should be doing. We need to continue inquiry so that we can understand what's going on here in an additional dimension. So we, as a clinicians, we understand the dynamic, and that's super important. I don't devalue that for a second. But then we want to complement that by saying, well, what do we know at the population level? So I just applaud when people are asking questions about, do we know this or can we ask that? I really appreciate that. Some questions we can answer, some we can't. But in terms of the BRFSS, it's an immense survey. 440,000 people sampled this telephone survey. There are banks of people who do the interview. And before 2013, the vision question was not a part of the core. But in 2013, as part of healthcare reform, HHS mandated that any HHS-sponsored survey needed to include the 6 disability questions that the ACS developed. So we're analyzing the available data, and so we just have the opportunity. We could not have done this before 2013, and we were not involved in designing the questions for the survey. CDC, however, did have a vision module that we implemented for, I think, 5 or 6 years, and there's, I think, maybe like 12 questions in the survey. And it was implemented in 22 states and has a scaled response. And if you look me up on Google Scholar, you'll see where I've addressed a couple of those, looking at a scaled response to that, not the BRFSS data. But we really don't have. We have the data available to us. It's got the questions that have utility to us. Some things we want to know, like have you received vision rehabilitation services, aren't available in that survey. So we're limited, but it's still a rich survey.
Yeah. One last question, John. Can you sort of comment on the cause-effect relationship between legal blindness or being blind and poor health? Like, is there a cause-effect relationship or
Well, I think we have to be really careful, super careful in the comments that we make. I think it would be too easy to do a blame the victim response, and that's the last thing I want to have happen with this. I think what we could go back to do is to this social determinants of health model. And so there are a lot of things that are going on in people's lives before they ever develop vision impairment. Or there's a lot of things if they're born with vision impairment and they have it at an early age, depending upon what the school systems are like, how assertive the parents are, that school experience may be good or bad for a child with a vision impairment. We know that. I know for my daughter, I mean, not to be personalize it, but I know that the trajectory of her life was different because I was middle class and could advocate for her. So we don't know what this is. We can figure that out having been in the field. Um, but I think trying to better portray these characteristics, and I'm using these terms of being dimensional, dynamic, and malleable. If we just think if we could redouble our efforts to get people into school and stay in school and provide appropriate education to them and supports to them so that they're successful, that changes the whole trajectory. And so the kind of the downstream effects can be great. And I think that so part of this has to do with disability rights, part of this has to do with just the circumstances that people were born into. But I think we're embracing this complexity can kind of help us. And we can say if people don't have, say, for example, adequate education, adequate options, health promotion, adequate income, all of those things can kind of define the trajectory. So it kind of gives us another way to look at the problem and define it in a way. Now I'll say this, I think is really one of the things I learned at CDC. Well, it's amazing. I spent half my career in vision rehab and then half my career at CDC, and they both complement each other. One of the things the CDC is really good at is deconstructing a problem, and that's what we're trying to do here. We want to better understand the dimensions of the problem, and then by understanding the dimensions, we can say, well, we can do something about this and this and this. And if we can do that with an appropriate intervention, then we can begin to bend the trajectories that we're seeing. And I think that's what's important about this. And that's the reason there's kind of a lifetime's worth of work here
Mhm.
in terms of better understanding what it is that's going on in all these findings. But I think for most of us, we can find ourselves in there. If you're interested in depression and mental health and behavioral health, it's in here. If you're interested in things like relating orientation mobility to exercise and conditioning, it's in here. If you want to relate what vision rehab therapists to exercise to nutrition, it's in here. I mean, it's so rich, and we need to just continue to explore this and refine the level of investigations into this kind of work.
Well, I think that's a great segue into us closing. Thank you very much, Dr. John Cruz, and all of you who joined us. I expect there's still lots more questions, so please don't hold back. Please email them to us so we can start discussing those, get them into the frequently asked questions. And I hope many of you will be at the conference that we will have in Kansas City, and we'll continue to have lots of conversations about big data. Thank you very much.